All right, let's dive into tropical sprue. It's one of those classic malabsorption syndromes that always seems to pop up on board exams, and it can be a real head scratcher in the clinic. So let's break it down. So picture this. A patient walks in, they've just spent a year in Southeast Asia, and now they've got this nagging chronic diarrhea. They're losing weight, they're exhausted. Right away, a few things should be lighting up in your brain. And by the end of this, you'll know exactly why tropical sprue has to be at the top of that list. Okay, here's our game plan. We're going to start with the what and the where. Then we'll get into exactly how it messes with the gut, what the patient actually looks and feels like, how you piece together the diagnosis, and, of course, how to treat it. And we'll finish up with some super high-yield pearls for your exams. So first up, what in the world is this tropical mystery? We've got to start with the basics. What the disease actually is, and maybe more importantly, where you find it. All right, the textbook definition gives us the key pieces of the puzzle. It's a malabsorption syndrome, which means your gut isn't soaking up nutrients. We don't know the exact cause, which is, frustrating, and it is totally tied to geography. The classic story is someone who spent at least a month in a specific part of the world and then develops this relentless diarrhea. And this map, this really drives home the most important clue for this diagnosis. Geography, geography, geography. You can see how the condition is packed into these very specific zones. Seriously, if your patient has never been to one of these areas, tropical sprue just plummets down your list of possibilities. And to be really specific, we're talking about places like the Caribbean, parts of India, and Southeast Asia. But here's a fascinating little curveball to remember. For some reason, we still don't understand. The disease is almost unheard of in Africa. That's a super useful tidbit when you're trying to narrow things down. Okay, so now that we know where it happens, let's talk about how it happens. What is actually going on inside the gut to cause all this damage? Well, while we don't know the initial trigger, we've got a pretty good working theory about the chain reaction that follows. The leading idea is that some kind of infection kicks the whole thing off. You get this overgrowth of certain bacteria in the small intestine. Think things like Klebsiella and E. coli. These little guys then start pumping out toxins that directly attack the intestinal lining. And boom, that's what leads to the malabsorption we see in our patients. Now, this is a really unique part of the story. Unlike a lot of other gut problems, tropical sprue seems to start at the far end of the small intestine, the distal part, and then it creeps its way backward, or proximally. You gotta remember this bottom-up pattern of damage. It's a key feature. Right, so we've got a damaged intestine. What does that actually look like for the person sitting in front of you in the clinic? Let's connect the dots from the pathology to the signs and symptoms. The effects of malabsorption spread through the body fast. A finding like this, darkening skin on the palms, isn't just some random skin thing. No way. It's a huge clue pointing straight to a vitamin B12 deficiency. It's a perfect reminder that what starts in the gut definitely doesn't stay in the gut. The gut symptoms make perfect sense when you think about what's not being absorbed. All those carbs that aren't getting soaked up, they pull water into the gut, and that gives you that osmotic diarrhea. The fats that are left behind, that's what leads to those pale, bulky, really foul-smelling stools we call steatorrhea. And all that rumbling and gurgling, that's just bacteria having a party with all the unabsorbed carbs. And systemically, the story gets even bigger. You see pallor because of anemia, especially from low folate and B12. Swollen ankles from low protein. A sore, inflamed tongue, or glossitis from B vitamin deficiencies. Every single one of these signs is a clue that points back to a specific nutrient that the poor, damaged gut just can't absorb anymore. Okay, so we're suspicious. The history and the physical exam are all pointing in one direction. But how do we actually prove it? Well, this is where things get a little bit tricky. Listen up, because this is an absolutely critical, super high-yield fact. There are no official, universally agreed-upon diagnostic criteria for tropical sprue. It's what we call a diagnosis of exclusion. You have to put together the travel history, the clinical picture, and some key lab findings, all after you've ruled out everything else it could possibly be. So what's our evidence? Well, first, a stool exam will show all that extra fat. Second, the blood work will almost always show a specific type of anemia, a megaloblastic anemia, which is most often from folate deficiency. And finally, the biopsy is the clincher. It'll show a damaged intestinal lining, what we call partial villus atrophy. And speaking of that biopsy, the #1 condition you need to tell apart from tropical sprue is celiac disease. This table is absolute gold for exams, so pay attention. Sprue is limited to the tropics. Celiac is everywhere. The biopsy in Sprue shows partial atrophy. In celiac, it's often total destruction. And the ultimate test? Sprue gets better with antibiotics, while celiac gets better with a gluten-free diet. Big difference. Okay, we've nailed the diagnosis. So what do we do about it? Let's talk about the management plan. Thankfully, the treatment is pretty logical and it tackles both the root cause and its effects. The treatment is really a two-pronged attack. First, you have to go after that bacterial overgrowth with antibiotics, and the classic choice is a long course of tetracycline. Second, and this is just as important, you have to replace all the nutrients that were lost. Folic acid is absolutely essential. I mean, sometimes just giving folic acid can lead to a huge improvement all on its own. Now, the prognosis is pretty good for most people who get treated, but you need to know this number. About 20% of patients will relapse after they finish their antibiotics. And unfortunately, those relapses are tied to a much poorer long-term outcome. All right, time to pull it all together. Let's do a quick high-yield review to make sure these concepts are locked in, both for your exams and for when you see this in real life. Okay, quick pop quiz. What's the earliest and most prominent vitamin deficiency you see in tropical Sprue? Just think back to the pathophysiology. The damage starts at the far end of the gut. That megaloblastic anemia from folate deficiency is often the first big lab finding to show up, sometimes months after the diarrhea starts. So the answer is for sure B, fully. And here they are, your take-home messages, the absolute must-know clinical pearls. If you remember nothing else, remember these 5 things. 1. Geography is king. It's your #1 clue. 2. Folate first. That anemia is the hallmark lab finding. 3. Distal to proximal. Remember that unique damage pattern. 4. Dual therapy. It's antibiotics and supplements. And 5. It's not celiac. Know how to tell them apart. And I want to leave you with one final thought. If this whole thing really is triggered by some kind of bacteria, what does that mean for public health? It kind of pushes us to think bigger than just one patient at a time and to start considering things like improving sanitation and ensuring access to clean water in these areas. Something to think about. Thanks so much for joining me.